Thank you. So I'm Kath Duggan and I'm the integrated care... Sorry? That's all right. My mum calls me Kate. I can be Kate. So I'm the Oh, and I busted my button. I knew I'd do that with excitement. So I'm the Integrated Healthcare Officer for Hunter New England and Central Coast Primary Health Network, and we're located in New South Wales. And my area of work, and probably for the last 3 years, which I've been privileged to undertake, is in cancer screening. I just also want to say thank you for the gold frog as our reward for this afternoon for the speakers, and I hope I will earn it. Now, just move that along. Okay, I did want to... Oh, sorry, I jumped ahead. I wanted to acknowledge my co-author, Dr. Ellie Warren, who is instrumental, yes, there's from Yeran, our Aboriginal Medical Service. And I do want to acknowledge my wonderful team here in the front who've come to support me today and are instrumental in the delivery of the work that we do around cancer screening in our PHN, so thank you, girls. And probably a disclaimer, there is some stats involved in this presentation, so sorry about that. And also, I will also state that I have a very strong passion for bowel cancer screening. I shouldn't be biased, but I see that is where we need to do so much work in our communities. So there will be a bit of a, don't forget bowel screening. Okay, moving on. So what we do know that participation in cancer screening programs is the single most important thing that we can do to reduce the burden around and illness and mortality for cancer. And what we are aiming to do with screening is earlier diagnosis. So whilst we'll still have incidents with cancer, we can impact on the stage of diagnosis, and that's what we need to work on. General practice has a key role in screening with the endorsement, and this has been shown in evidence, that the endorsement by clinicians, practice nurses, GPs, and also that whole of practice approach is key to driving change and encouraging patients to participate. In Australia, we have 3 key population screening programs: the National Bowel Screening Program, the Cervical Screening Program, and the Breast Screen Australia program. This was our state-based stats, but it's pretty well the Australian story. So about 1 in 2 people are participating in cervical screening, 1 in 2 for breast screening, and roughly 1 in 3 for bowel screening. In some communities, particularly our Aboriginal and Torres Strait Islander communities, these rates are a lot lower. We don't even have the statistics for that because we're not recording that. So that's even more important of why we need to be more diligent with the work that we're doing in general practice. So what we did to understand, so what the story is this afternoon, or why I'm here, is to speak about when we started this work a few years ago, and with Dr. Warren, she was, well, how do we know where to start? What's the problem? What are the enablers and barriers? What can we do, and what's the local story? So with that, and I don't know why I bring notes because I never read them. They made me feel better. So what we wanted to understand was the behaviours and attitudes of clinicians, both practice nurses and GPs, around cancer screening in our area, so that we can develop strategies that were specific and localised. But I think the story that we unfolded was, we didn't learn anything new, but we validated what we thought we knew, which was really powerful, and it was enabling us to go out there and say, this is what you told us and this is how we've responded. So what we did was undertake a clinician survey, and we're very fortunate, with some of you will know the cervical screening renewal in 2017. On the back of that, there was a lot of interest by clinicians to understand the new program. So what we did with that was had some large education events, and with that we were able to use our survey, which was qualitative and quantitative, to understand that information, or that knowledge and that attitudes and behaviours of GPs. That would be about it. So we'll jump to the results, which is here. Buckle up. We'll just go into stats land for a little while. I didn't realise what a data nerd I was until I started to do this project. I thought, oh, this is really quite fascinating. I hope you find it a little bit interesting. So literally we had 3 events in 3 areas, and it was really, we had a good spread, which was not planned, but was quite lucky that we had fairly even responses across the 3 regions. So 77 GPs and 70 practice nurses participated in our survey. So what we asked first was the feeling of responsibility around screening and that timely screening. So, you know, we know screening happens at intervals, so, and I won't go into that now because we don't have time. So the blue represents cervical screening, breast is red and bowel is green. And what you can see there is, particularly from, and I know we are in the practice nurse world here, so what we saw was an increasing, I suppose, responsibility as in when we look at neither, so I should have a little thing, but when we look at neither there was an increasing, I should have gone to the stats lecture. Upward trend, thank you, my team. Upward trend for that ambivalence around. So we're much more connected to and understood cervical screening and felt it responsibility. Not so much breast, and then bowel was probably where we need to do some more work or have some more responsibility. Now this I thought was really powerful, but it did indicate what we did know, was the use of practice software, the reminders and recalls in general practice around cervical, breast and bowel screening. So the blue represents the use of the software for reminders, but the red actually represents that sending out actively attracting patients through SMS or reminders out to them. And what you can see, once again, I think traditionally we've owned cervical screening. As practice nurses, we've undertaken cervical screening in general practice, and there's been a strong connection to that. Breast happens by the breast screen vans that are out there in the community. It happens away from us. And bowel screening even more so. The kits come in the mail, so it's quite a disconnect or far away. So what we did see was that only 18% of clinicians would actually actively remind their patients to participate in the National Bowel Screening Program. And it's such a contradiction when we know that bowel screening participation is only 30%, roughly, and it's our second most common cancer in our community. And about a third of people get diagnosed when the cancer's in the local phase, or within the bowel. So we're missing such an opportunity. And those who are diagnosed early have a 90% survival rate. So our opportunity and our connection, there is a big disconnect. So reminders and recalls, having a role dedicated, there was about 61% of the GPs and practice nurses who felt that they would be likely or very likely to establish a role that would drive reminders and recalls. And I think heading into the age where quality improvement and data-driven quality improvement, reminders and recalls, having clean data and using that data to work with our populations and improve health outcomes is very powerful and a great opportunity. So not a disadvantage. We did see it as a great opportunity. This was my probably most aha moment, and where we've got great opportunity. This isn't we're doing badly, this is where I see an opportunity. So when we're looking at, once again, for our practice nurse population, in the green, we've got not likely, and so this number here, that's 30% of practice nurses who were not likely to raise bowel screening in a standard consultation. Now that's not, yes, it is a bad thing, but it's an opportunity to think about how we can change that and what we can do and the reasons why that's occurring. And it is time. It's a multitude of things, and it's probably an opportunity to do a little bit of a deeper dive into those reasons and how we can work better together. The other great thing I think we saw, or the opportunity or enabler, was around using health assessments. So those opportunities that we see within everyday work. So in our 45 to 49-year-old health assessments, and I know there's a varying uptake, we'll use that word, of those assessments, but a great opportunity because breast and bowel screening, you're just at the beginning, turning 50, that's when it's all going to start happening. So it's a great teaching opportunity. You know, when you get to 50, you're going to get that kit in the mail. When you get it, this is why you should do it. Do you know about your family history? There's great opportunity to have that conversation, and then that kit comes in the mail. Oh, I know that because I had that little bit of a pep talk. And so it's a great place. And both GPs and practice nurses saw those health assessments as an opportunity, particularly our 715 health assessments, because we do know that bowel screening participation and all screening is a lot lower in our Aboriginal and Torres Strait Islander communities. So this was what general practice said they actually do. And I guess it's back to the 35% is using their data and systems. So our reminders and recalls, our patient registers, using our actions and reminders or top bar prompts, whatever it is, but it's using that data and systems to actually improve. And this is what they said they're doing. So we've married up the opportunity with what's actually happening, but we just need to build on that. We saw that opportunistic screening, that's the blue section, was another place that people were using it, but obviously we can do a little better. Education and health promotion, so using those, and I guess tying that back to our new accreditation standards, where we know that recording of those health promotional preventive health activities is something that we must do. So there's an opportunity there to continue to do that and to build that into what we're doing within those health assessments and those conversations we're having. So our survey, it was a great experience, but it was a huge amount of work, and you don't realise when you think, oh, just run a survey. There was 31 recommendations that came from that survey, and from those recommendations, 5 sort of key areas emerged, which was looking at our clinical leadership, particularly for bowel screening. We needed to do some work about peer-to-peer conversations, clinicians being engaged, the understanding and building the role of particularly GPs connecting. And I've had many clinicians say to me, well, it's the patient's responsibility. It comes in, and I know you look like that, but that is how I get called to go to practice visits with our primary care improvement team to have those difficult conversations, to raise the issue. And it's difficult when you've got, it's the patient's responsibility. They get the kit, they've got to take more responsibility for themselves. Well, if you don't understand why you should be responsible, then why would you do it? And so it's that connection about your health. But also for that clinical peer-to-peer, having that between nurses and nurses. So we've done a lot of work with our practice nurse networks and community of practices, so building that champion role. Oh God, I'm speeding along. I can just relax and talk about bowel screening. I think education has been a massive, and we've still got a long way to go. I know I've been chipping away at this for a couple of years now, but we've still got some work to do. So I just wanted to promote the fabulous webinar that APNA have available on their website for practice nurses and bowel screening, and I would encourage you all, if you haven't seen it, who has seen it? Woohoo! One. But it's there, and it's a fabulous resource. And it encourages you as practice nurses to get the kit from the national program, so you've got it there, you know what it looks like, you can explain it to your patients, you can understand what the program's about, so it makes you feel a lot more comfortable to undertake the screening. Whole of practice approach, and I think we've talked about this lots. It's so important. Everybody has a part to play, and I think when we use the Katrina Otto webinars, and we go into practices, and everyone's there around the table, and it's, well, how do the results arrive in your practice? What's everyone's role? Who does what? What's our conversation? And that probably brings us to the data and systems, so the work that we're doing to try and chip away with cleaning data. And I will do a little advertisement. If you're in New South Wales, but I'm sure you'll be able to access it from other states, Cancer Institute New South Wales are developing online modules for cancer screening, and I think we're in the editing stage of Module 2, but they will be out later in the year, and I think they'll be a fabulous resource that will link to your practice software, using your data extraction tools. So it'll be very, very informative, but I know other states have different resources, but I think it'll be a good resource to have a look at. And our community engagement, and I think it comes back to that GP saying, well, it's the community's responsibility, and we do see a lot out there that's pink, and we do, I guess, as I know there's many women in the room, but it's been, I suppose, you just know that when you get to a certain age, you've got to go and have that speculum examination, and we kind of just have a general understanding, and that's what happens, even though we still hate the experience and people aren't doing it enough. But nobody's talking brown out there. Except me. Though Tasmania, anybody from Tasmania? Yes. Do you know the slogan? Sorry, that's putting you on the spot. I really like it myself personally. It's simple. It's just poo, poke, post. And that's all we need to know. And I just think, and I don't know if you're from New South Wales, you've seen the ads there, and sorry, Cancer Institute, but the lady sitting there, she said, I'm going to get a kit in the mail, and I'm going to do a poo and poke it with a stick. And it's like, oh my God. But anyhow, but poo, poke, post with a evangelic choir behind seems a lot more appealing to me. So have a look at that. So I think getting the community on board, but what you can do with that with your health promotion, and I know we've done it with our quality improvement activities, is looking to include it in Bowel Cancer Awareness Month, your whole practice. That's the focus. And we had a really great example where practice manager, she drove the whole, within one practice, larger practice, walked in the front counter, right there is a bum. behind from Bowel Cancer Australia. It was legitimate. And, so it's like the patient, like, what's that? What's that about? And it starts from the front counter. It's everywhere. Every clinician's screensaver was a poo emoji. There was no escaping the bowel cancer message. So having those kinds of things but it's patient education. So, and I would say the first cut's always the deepest. The first time you do your kit, the next one will be easier. So I think if we can get people screening and those earlier adopters using our health assessments is so valuable. So I'm going to finish now by inviting you all to be cancer screening champions in your own world where you can. And just remember that, just one conversation can encourage someone to participate who may not have ever thought to do it before. So thank you all very much.